So my name is Norah Crossnohere, or Noni Crossnohere. I have identity issues. I am a research associate at Ohio State College of Medicine, and I'm also finishing up my PhD in public health at Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland. So it's really, truly my pleasure to be able to come up here and talk to you all today about some of the work that we've been doing around patient experience in Duchenne and how to measure patient experiences and preferences. And I think it's really kind of nicely placed to have this session right after the advocacy session, because now we're all jazzed up. All right, we've got to be heard. What are we going to do? So I'll give you at least a little bit of snippet in terms of, from a scientific perspective, what is the work that we're doing to try to quantify patient voice. So none of the work that I'm going to talk about today would be possible without the engagement, the collaboration, the intellectual effort put in by people that we've been able to work with from numerous different countries on this project. So we have stakeholders who have participated in and given us so much feedback here from Canada. We'll thank Rick Moss and Megan Zinn for all of their effort over the past year or so on this project, as well as folks from Belgium, Australia, US, Netherlands, and the UK. And so, of course, further, this work is not possible without the people who are participating in our research, who hopefully many of you may fall into that bucket by the time I get out of this presentation. So I'll preemptively kind of thank you for that work. So today, I'll talk about three kind of major areas that we've been focusing on, some motivational questions. The first being, why is it important to study patient experiences? And why do we want to think about this not just within any particular country, but internationally? Next, we'll talk about how much is it that Duchenne impacts quality of life, and how is it that we can measure that really well so that we can make informed decisions. And finally, we'll talk about benefit-risk trade-off. What benefits and what risks are people willing to take were a new treatment to arise? And how do we rigorously identify that information so we can use it to inform policymakers about how much risk you're willing to take? So first, our big picture. Why do we do this at all? So in the words of a parent of a child with Duchenne, when it comes to terminal illness, the regulator's job should be to make sure that a product is safe and that the risks and benefits presented by the producer are accurate. Our job should be to determine, given all of that information, whether to give it to our children. It is an immensely personal decision that involves the parents and the child with Duchenne. So this quote paints the story of two different paradigms. We've got the people with Duchenne, we've got their parents, we've got these barriers. On the other side, we have the regulators who are controlling access, who are acting as a stopgap between maybe what you need. Is it possible for us to bring these two perspectives together? Is it possible for us to kind of take down some of these silos? Well, increasingly, we're seeing that it is. So perhaps no duh to most of us in the room, but you are the experts of this condition. You are the experts with Duchenne. And we're seeing the regulators, at least in the US, are increasingly having interest in understanding your perspectives, understanding your experiences, and using this information to make better and more tailored treatment options available. And it's not just in the US, I will say that. Here in Health Canada, we're at least starting to see these programs that are really focusing around how is it that we can meaningfully integrate patient voice into our decision making? How can we do that transparently? How can we do that in a way so that all stakeholders can be involved and it's not just a men in the back room making these decisions for everyone else? So patient experience data is a big kind of umbrella term, but what does it mean? So patient experience data can encompass things like the symptoms of Duchenne, the experiences that you might have with treatment, the side effects from those treatments, the burden associated with a treatment or associated with not having a treatment. What are your preferences? What is it that you want to see and you're not seeing? So it's this big area of really just trying to understand how the condition impacts daily life. And having this information can be important throughout the entire life cycle of a treatment. It can be important on the front end when we have drug developers and pharmaceutical companies thinking about, I want to develop a new treatment for Duchenne. What should I be focusing on? Is it important to create a treatment that's going to elongate life? Should I be focused more on slowing progression of disease? Where do I put my efforts? It's also important from a regulatory standpoint because it allows people's voices to be heard in the decision-making process. If the Duchenne community indicates that they're willing to take a risk in certain areas, who is the regulatory community to say that that risk is not worth taking? And what we're seeing is that there are many different ways to go about integrating and collecting this patient voice information. So from an advocacy perspective, one of the things, and I think the previous presenters did a far better job than I ever could, but one of the approaches that we're seeing is this really kind of detailed narrative style, often being taken by advocacy groups, these white papers, this expression of what it's like to have Duchenne. How do you communicate this in a language to someone who doesn't have Duchenne or doesn't have a family member affected? How do you portray this story? We also see the research perspective, which of course is kind of where I fall. How is it that we can systematically and rigorously collect information about your lives, about your experiences, and integrate that into a scientifically relevant framework that makes sense to a lot of different stakeholders? And third, we can see how this affects guidance. So what we're increasingly seeing in the US is that patient communities have had the opportunity to work with groups like the FDA to help write down what is important to them. And that information is so vital because then it's used down the line when we make decisions about what is and is not approved. So what are all of these different pieces of information telling us? Well, there's a lot, but one of the most meaningful things that's come out of our work thus far is that we're seeing this differentiation between treatments that improve quality of life and treatments that elongate life. Not to say one is necessarily more important than the other inherently, but what we're seeing from the communities that we're talking to and the people that we're talking to is that having treatments available that make life better, that slow disease progression, are more important than just having treatments that make that lifespan longer. So I won't get into too many of the details of this graph, but what we see here is two different types of treatments. So we wanted to compare different possible benefits and see what resonated with folks. What would people want in an ideal world? So what we see on the left is the quality of life measures. What effect does it have on muscle function? What we see on the right is the length of time that you would spend, an elongation of life. On the y-axis here, this relative best-worst score, basically the way to interpret this is the higher the dots, the more preferred it is. So what we're seeing is that this quality of life, this effect on muscle function, those dots are higher. People are more likely to prefer that a treatment is going to improve life here and now and are less so interested in just extending life as it is. This is something that regulators don't always think about. While not to say this is generalizable to everyone or every group or every family, it's important to know that there are people out there who don't necessarily only want to think about elongation of life, and that maybe if a treatment came up that improved quality of life but not elongated it, that we should be considering that. So this is the context that we're living in. But what is it that we're going to do moving forward? How do we engage each other? How do we motivate? What do we want to do as a community? So we did some qualitative interviews in 2016, asking all of these different international stakeholders what research could do for them, what patient experience data could do for them, and how we could use it to improve the advocacy work that they were doing. We had three main themes emerge from that. The first was that anything we did should have some component of international generalizability. So we should look and see if there are similarities or differences between different places. Duchenne is siloed in the sense that there are so many different processes and procedures and regulations you have to deal with in your country. But in reality, the Duchenne experience is very similar internationally, that natural progression of disease. So this was this idea of strength in numbers. We want to know if we need to be fighting in silos or if we can all work on this together. The next component that came out of this was that there was some need to measure these benefit-risk trade-offs. So again, people routinely make decisions that force them to weigh how good something is against the possible side effects that it might do more harm. And understanding what those differences look like, it would be meaningful to this community. Finally, there was a need to consider the regulatory contexts. So nothing that we do should be just for scientific thought. We should have real-world practical applications. How do we move this forward? How is this going to help the field? So it was with all of that in mind that we started to develop this international survey trying to document the experiences of people with Duchenne and their families and treatment preferences for hypothetical kind of emerging drugs in Duchenne. So this survey is now open. We are actively recruiting. We are aiming for a total of 60 people to participate from each of our 6 partner countries. So that would be 360 people. That would be a lot of people for one survey from a rare disease community. We are online, the survey. It's easy to take. You can take it on your computer. You can take it on your smartphone. And we have 4 sort of modules that we present folks to. The first is just a little bit about your background experiences. What sort of clinical characteristics do you have? What's kind of happened? What kind of medications have you taken? Next, we ask folks about their treatment experiences and their treatment preferences. Would you rather a drug that makes the disease, that slows progression of the disease, or that has an elongated life component? What are the things that matter most to you? Third, we talk about unmet needs. So what is it that you would want to see out of advocacy programs in your community? What is it that you would want to see out of regulators? And finally, we ask some basic questions about you. So to date, we've had around 200 folks participate, which is really, really wonderful. I think we're off to a good start, and I'm certainly hopeful that we will hit that 360 mark. Amongst those folks who have participated so far, we can see the majority are people from the US, around 39%, followed by the UK, around 36%. Canada's at 8%, so here's my ask, my one ask, right? That if you are interested and you think this work is important, that you participate in this research, there is a flyer in your packet, and then we can get that number up. What we also see amongst the 201 participants is that we're able to we have people who are really spanning the full age range of Duchenne. So we're getting parents reporting on their kids who are youngins. We're getting adults reporting on themselves up until they're in their 40s. So this is going to be a really great opportunity for us to look at how these preferences and wants and experiences change over the life course. So we're very excited about that. We're also, we had the opportunity for both people with Duchenne to report for themselves and parents to report on behalf of their children, irrespective of how old their kids are. So you can report on your kid who's 5, you can report on your kid who's 25. We're really open to all perspectives and opinions here. All right, so that's why we're doing what we're doing, and a little bit of a glimpse into how we got here. So what is it moving forward that we really want to do with this data? Well, one of the things we talked about was understanding how Duchenne specifically impacts quality of life. You know, quality of life, I think to each and every one of us means something a little different. It's a complex concept. No one's going to be exactly the same. But in a regulatory setting, we have a really clear understanding of what quality of life means in very specific ways that we measure it. And this is important because regulators make comparisons across different diseases based on quality of life. And what we see is that more resources get allocated to conditions that have a poorer quality of life, and more resources get allocated to conditions where treatments become available that have a really big impact on quality of life. So it's really important for us to know if the tools that regulators use are really accurately measuring the quality of life in Duchenne, because otherwise, when we use these tools, we're not getting accurate information. So the most commonly used tool by regulatory groups is something called the EQ5D. It's a 5 questions, 5 multiple choice questions. That's all it is to measure your entire quality of life. 1 multiple choice question each about mobility, self-care, ability to complete usual activities like going to school or work or hanging out with your friends, pain or discomfort, and anxiety or depression. That's the main way that we measure quality of life. The second way that we can sometimes think about quality of life is something called the Visual Analog Scale, or the VAS for short. And that's saying, on a scale of 0 to 100, how good is your life? Do you have the best health imaginable? That's being 100. Do you have the worst health imaginable? That's being a 0. And then you rate yourself. So we don't have results yet from that data. We're looking forward to seeing what that kind of looks like. Something that we anticipate seeing is Hopefully that these measures are really good at measuring quality of life in Duchenne, because that means existing systems don't need to be changed and we can focus on other priorities. But we are also going to be comparing those quality of life measures that are really, really general and can be used across many conditions, and look at our more specific Duchenne-related things. So we have a lot of questions in the survey about kind of your experience with Duchenne, where your life is, what is working for you. And we'll be able to compare that data and get a sense of how it looks over the life course. So our third component of this work is the benefit-risk trade-offs for treatments. So benefit-risk trade-offs is this is the weighing, right? How much good is good enough to withstand that bad? And at what point do those scales tip? Okay. So in our previous work, we've done a lot of studying on what benefits are meaningful and what risks are also things that people are truly concerned about. So I showed you that slide before about the quality of life or the disease progression maybe being more important than elongating life. So it was because of that we decided to put this, make that our major benefit in this research. So we're trying to see what risks people will withstand for a drug that slows the progression of disease. Okay, so what possible risks are we talking about? The first risk is the chance that the drug won't work. You know, these are all experimental treatments right now. Many of them don't work. Many of them only work for certain people, and that's something we want to consider. We also want to think about kidney damage. Once people see kidney damage on that new drug submission sheet, a lot of red flags go up. And finally, risk of fracture. Of course, fracture is a particularly pervasive problem in Duchenne that can have many impacts on quality of life. So we want to understand if people are willing to accept these fracture risks. So how do we actually get at these trade-offs? How do we ask people to make them? Well, what we do is we show people this task. And it has two hypothetical drugs, drug A and drug B, that vary across their levels of these 4 characteristics. So we say, all right, drug A is going to slow your disease progression for 5 years. That sounds pretty good, right? A lot of people are going to benefit, okay? And there's no extra risk of kidney damage and a 20% risk of fracture. Okay, that sounds not so bad. What about drug B? So that slows disease progression for less time, only 3 years as compared to 5. It has a lower chance that it will benefit people. Only 25% of people will benefit. It has a higher risk of kidney damage, but it has a lower risk of fracture. So who would choose drug A? Yeah, me too. Right? So this is I don't want to say easy, but this is an easier scenario. It's, for the most part, is clear-cut which choice you would make. But you can imagine that what if they both slowed disease progression for the same amount of time, but one had a higher risk of fracture and the other had a higher risk of kidney damage? Then we start to get into the nuances of what are these trade-offs that people are willing to make. So this is a snippet, not of data from this study, but from a very similar study in Duchenne in the US in 2016-ish, 2016, we'll say that, looking at a very similar instrument in terms of how does it perform and what sort of results do we get. So what we have along the bottom here is this maximum acceptable risk, or how much risk people would be willing to take if a drug slowed your disease for 1 year. So then we have 3 different groups. We have professionals, so these were clinicians, these were people who work at pharmaceutical groups in industry. We have caregivers, so parents, and we have patients, so adults with Duchenne. We'll focus on the patient group, that darker blue bar, the 3rd kind of level. So what we see is that adults with Duchenne were willing to accept an added 7% risk that a drug would increase their chance of fracture if it slowed their disease progression for 1 year. They would also accept an added 4% chance of kidney damage and a 7% chance that the drug just wouldn't work if there was this possible benefit that it would slow disease progression. We can compare that to caregivers in that green bar, and they're willing to take a lot more risk in all 3 of these categories. They'll take an added 30% chance of fracture, an 8% chance of 8% chance of kidney damage, and a 21% failure rate. So we see how these differences are meaningful, and we need to not only think about how the community overall will take benefits and risks, but how it looks different amongst people with Duchenne and amongst their parents. So I've presented a lot of stuff in the US, but what do things look like in Canada? All right, so I need your help for that one. The value of research like this is that it allows us to have the opportunity to equally represent people from all different countries. Our plan is that we'll have an equal number of participants from everywhere. But we can only do that if we have people's participation, and if people are able to complete this research, share with their friends, share with their families, if so you think it's meaningful and important and you are okay with doing it. So we've completed We've completed recruitment in the US and the UK, and we're still actively recruiting in Canada, amongst a few other places.
Hold on. I'm losing you. I'm overheating the batteries.
I can just kind of go in. Do you want me to use this? The other microphone?
Maybe just walk to the other microphone for now. Just grab it.
Hello? Does that work?
Yep.
Yeah. Okay, good. Ready? Okay, great. We completed in the US, UK. We're still ongoing here in Canada, amongst a few other countries. I Googled, in the US we have this thing, it's like, when they were recruiting for World War II, it was like, we need you. And I was like, what's the Canadian corollary to this? And of course, what came up was a poster about teamwork. So you guys really have us beat on so many levels. But I had to share that part. So next steps for this work is that we have to complete our recruitment. We need more people. Please spread the word. We plan to disseminate all of these results back to the partner groups that we work with. You know, we don't do this work for us alone. We do it so that it can be helpful, it can be beneficial, can help inform kind of what is going on. And our ultimate hope is that we'll be able to use this information in conjunction with your advocacy groups to inform regulators and industry. So if a new drug comes up and we have all of this information about preferences, we'll be able to say, you know, this is what our community has said is important, this is how much risk they will take, we think it should be approved. Or vice versa, nobody wants this isn't good, why are you spending your time and money developing this? So I think with there, I will come to a close. This is the picture of the flyer. It's in your packet. Please feel free. I'll be here all day to reach out if you have questions about the research specifically. I'm also happy. I'm sorry if I don't know what time we started. I got a little thrown off with the break. But I'm happy to take a few questions if we have a moment for that. And if not, you can come and find me afterwards. So thank you all. Yes.
Hi, you're asking a question that I don't know if many people know the answer to, because I don't know if they know what kidney disease implies. Hi, you're asking a question online about a topic that I don't know if many people would know what it implies. For example, kidney disease. Everybody can picture a fractured bone, but not many can visualize what kidney disease does. So I think it's very important to clarify what you mean by that and what kidney disease implies. Just a criticism of the study that I think that needs to be addressed, okay?
Yeah, so thank you for that feedback. On the actual survey itself, we do have some information about all of the different, you know, we don't just throw people into the deep end here, take this, there's vignettes, there's text leading up to it. I believe we have vetted it with our different community organizations, so I would hope that that would be more input.
Just a concern.
Sure, thanks.
Any other questions?
Okay.
Well, thank you, Nora. Appreciate that. And you're here for the rest of the day as well, so ask her some questions at lunch or in the afternoon break as well.